My name is Jack Aiello. I live in the San Francisco Bay Area and was diagnosed with multiple myeloma 29 years ago at the beginning of 1995. For me, and maybe for you, it started with a backache. Except for me, MRIs and x-rays didn't show anything wrong with my back, according to a back specialist I went to see. But I ended up having to take a blood test, and that blood test showed an elevated protein. And the back specialist said I likely have multiple myeloma. And that was the start for me of about 8 years of significant treatment. Back then, the average lifespan for myeloma with treatment was only 2 to 3 years. And so I was fortunate to respond to a third transplant, except that I used donor stem cells in that transplant after a couple of earlier transplants and clinical trials didn't work for me. So I'm extremely appreciative to be alive 29 years later.
Hi, everyone. My name is Cindy Shimoleski, and I've been living with multiple myeloma since 2008. And what brought me to the doctor was probably this very debilitating back pain. And the back pain was so bad that it affected my job. I was having a hard time standing up to teach. I wasn't able to take my class on the playground for recess. I had to have other teachers do that. So I went to an orthopedic doctor. And unfortunately, I think my orthopedic doctor was unfamiliar with the symptoms of multiple myeloma because he diagnosed me with degenerative disc disease. And it took an additional 2 years to get the correct diagnosis of multiple myeloma. Since that time, I've had several treatments, and now I am doing very, very well. And I'm really excited about today's show is because I'm hearing all these new therapies that will be available to me if and when I relapse. Hello, everyone. Today I have the pleasure to introduce Dr. Fonseca, who is a hematologist oncologist and Chief Innovation Officer with the Mayo Clinic with a special interest in multiple myeloma. Welcome, Dr. Fonseca.
And it's my privilege to introduce Dr. Susan Ball, who's a hematologist oncologist with the University of Alabama at Birmingham, with a special interest in myeloma and CAR T therapies.
Yes, Dr. Ball, we're very happy to have you today. And Dr. Fonseca, we're lucky now. There's so many treatments available. When I was diagnosed back in 2008, the treatment arsenal was not nearly as filled as it is now. So with all these treatments that are now available, what are some of the considerations you think about when choosing treatments for different groups, like transplant eligible versus transplant ineligible and newly diagnosed and high risk? Like, what goes through your mind?
Thank you, Cindy. That's the essence of everything we do in the practice, right? All of those considerations, and then how do we present them and share them with patients as options for their treatments. When we started seeing all these drugs come forward and being approved, my first reaction, and probably that would be of anyone, would be, boy, this is going to get complicated. How are we going to choose? And we have all these treatments, and maybe my appointments are going to have to be 2 hours long because I have to present everything to patients. But as it's true with everything else in medicine, the availability of additional information has allowed us to narrow down what are the best options for patients, such that even though we have many more drugs, we still have 1, 2, or 3 options that are probably the best for a given step for a person. So that has allowed us to work more on our messaging and the rationale of what we do. I think the considerations you mentioned are critical. So we always want to look at, first of all, the patient as a person, and as a person with their preferences and what their goals are, as well as some of the issues related to their own health, what we physicians would call the comorbidities of the patient. Now, one of the critical aspects for that, and one we can't modify, I know many wish we could, is our age. Age is a major determinant on how well you're going to be able to tolerate treatment or not. There are some treatments that become quite a bit toxic as we take them later on in life. A great example of this has been the stem cell transplant. So we as physicians and clinical teams have to tailor our approach to patients as we start proposing the various treatments. The second consideration is what you said, is whether the patient is newly diagnosed or whether this is someone who unfortunately has now myeloma that is coming back, what we would call recurrent myeloma. And if we think about that, then we say, okay, which stage is this? Is this an early recurrence, or is this someone who has already received 3 or 4 prior lines of therapy? Then we bring other factors that I think it's important that patients know about and we discuss with them, such as what we would call the biology. We like to test the myeloma cells for the genetic makeup. By the way, I'm going to put in the comment here because this can easily get confused. When we talk about genetics in myeloma, we're mostly talking about the changes that occur in the myeloma cells, not the genetics that a person may have in the rest of their body. And very importantly, not genetic things that are passed on from generation to generation. These are just the changes that occur in those myeloma cells. But those are things that play into our decision-making process. Some patients have markers that would make us more concerned, something we call high-risk myeloma. And with that in mind, we put together treatment plans that we propose for our patients. I think we're moving forward with a more unified approach to goals. If you go back 15 years, or certainly 1995, Jack, you were mentioning, our goal was control. Our goal was, can we do something that will put the myeloma under some control at bay that would allow us to gain time? I think many of us feel like the pendulum has swung completely the other direction. I think many individuals, myself included, think that we should aim to eradicate all myeloma cells and ultimately produce cures for patients. So I think how you sort of phrase that and plan for that becomes important. And behind that, there's a whole set of other principles. But probably I'll stop at that point and say those are some of the overriding things we think about, but always starting with a person, which is that patient.
So, Dr. Bowe, when I introduced you, I said I saw a presentation at the American Society of Hematology meeting, which was this past December. Can you explain the importance of ASH, and then what, from your standpoint, were the biggest takeaways from this year's ASH?
Absolutely. So the ASH meeting, or the Annual Society of Hematology, the American Society of Hematology meeting is a key event for hematologists in the year, and it's really where we expect to see some of the latest and greatest of the science and all the discoveries and innovation that's occurring within the field. And it's a one-stop shop where we get to see some of the best data. So certainly it's a very looked forward to event in the community. This ASH was no different. In fact, we were lucky to have 2 major presentations at the meeting, including a plenary session where we saw results from the ISKIA trial, as well as a late-breaking session where we saw results from the Perseus trial. So I'll break it down, and I'll start by talking a little bit about the Perseus study. This was perhaps one of the most awaited trials, in the sense that this was a randomized phase 3 trial evaluating a quadruplet regimen of daratumumab, bortezomib, lenalidomide, and dexamethasone versus the same combination without daratumumab in patients with newly diagnosed transplant-eligible multiple myeloma. And for many in the field, we have moved towards using these quadruplets based on an earlier phase 2 randomized Griffin trial. But this was practice affirming and perhaps practice changing for a small proportion of patients in the community. What this trial did was take patients who are transplant eligible, so those patients who are fit in the European and Australian countries, which is where this was predominantly performed, and patients were randomized into receiving 4 drugs versus 3 drugs that I just mentioned, followed by stem cell transplant, and then a doublet maintenance following consolidation therapy with the same regimen. And what we saw was overall that with a close to 4-year follow-up, that patients who received this 4-drug regimen did a lot better and had longer progression-free survival at the 4-year time point. And patients had a very deep response with this regimen, achieving measurable residual disease negativity, both using very sensitive markers and sustaining over prolonged periods of time, which has been shown to really be hopefully a surrogate for improved patient outcomes overall. So this was, like I mentioned, within the US, many in the field have already taken up practice of adopting this 4-drug regimen based on the prior Griffin study. But I think this was confirming and affirming for those of us who are doing that, and then practice changing for those who were still using the triplet combination. And I think this was perhaps one of the most exciting things to come out of this trial, among other things.
So that's fantastic. And Dr. Fonseca, what about you? What can you describe maybe an outcome you saw from ASH, which was so important to the myeloma community?
So it's a wonderful time for us, and more so given the progress we're seeing in myeloma. But I think the fact that we have now very strong data for what needs to be done in frontline is very important for patients. I think that at this moment, it's beyond any doubt that we need to use the best treatments up front. And for now, that means the incorporation of this monoclonal antibodies, the CD38 antibodies. Dr. Ball mentioned, of course, the use of daratumumab. We also have the similar molecule, isatuximab. But the clinical trials really point to outstanding results which could not be seen ever before with the treatment of myeloma. In fact, the results are so good that they're now are going to start challenging some of our assumptions. So if you remember, almost 10 years ago now, we had the meta-analysis for the maintenance strategy for myeloma, where patients go through that induction, they get the transplant, and they're placed on maintenance. But Dr. Costa has pointed out repeatedly that those maintenance studies were done where we could achieve a complete response in about 30 to 40% of patients, minimal of this MRD negativity, and sometimes patients were getting 2 drugs as induction. So one would say, well, no surprise that more treatment was effective, whether we call it maintenance or consolidation is just semantics. And now we're getting to the point that many patients have a complete response, and we have studies that are showing, and depending how you measure and the threshold, that somewhere between 60 and 80% of patients can get into minimal residual disease. So we're starting to ask questions. Do you even need maintenance in those patients? I don't claim in any way that we have the answers, but it just reflects how fast things are moving forward. And breaking it down, as Dr. Ball did, I think is critical. For some people, we were practicing this. But for other people, either they need this for regulatory purposes across the globe, or their reading of the medical literature is such that they want to have that phase 3 trial before they change clinical practice. I think right now it would be a rare patient that should not be offered induction therapy with something as we were describing. And in fact, a lot of things are getting simplified. Just yesterday in a conversation with colleagues, I was thinking I could put out a message on Twitter and say, the treatment of myeloma should always start with something like daratumumab, lenalidomide, and dexamethasone. And then the secondary question is whether the patient needs to get a proteasome inhibitor like bortezomib or Velcade, as known by patients, or carfilzomib, Kyprolis, and whether they need to get a transplant. But then things get simplified because the best players rise to the very top of what we're doing. So I'm excited for what this means for patients.
I completely agree with Dr. Fonseca. I feel like some of the things that are almost becoming cleaner as we go. I remember this discussion about 3 years ago where everybody wanted to know, would you give DARA to a transplant eligible patient? Would you give DARA to, I think the answer is becoming clearer and clearer and clearer that, you want to use your best drugs up front and really make that first cut your deepest. And I think I answered recently when somebody asked me, is there a patient you would not give DARA? And I said, I don't know who that would be, because it's such a well-tolerated, effective therapy that now I'm thinking more, like Dr. Fonseca said, about which of the other agents you could potentially get rid of or improve upon, rather than the DARA aspect of it. So I think the answers are becoming cleaner.
Yeah, that's great. Dr. Fonseca, one of the important trials, and Dr. Ball referred to it earlier as having been given special recognition at ASH as a plenary session, was the ISKIA clinical trial, which compared carfilzomib, Revlimid, and Dex, adding isatuximab to it or not to it as frontline therapy. Isatuximab is like daratumumab in that they're both CD38 monoclonal antibodies. So this is for transplant eligible patients. It was another 4-drug trial. Can you talk a little bit about that since it was given plenary status at ASH?
Yes, I mean, the reason something is given that plenary status is when the reviewers and the reviewing committee feels that there's something there that is of such high value that, reaches the highest standards of evidence, or that even potentially becomes immediately practice changing. And I think this particular clinical trial was one more point in that direction, where they start looking at the response rate and the MRD negativity rate for those patients. For those in our audience who may not be familiar, MRD negativity refers to the term of measurable residual disease or minimal residual disease, which is nothing different than saying we have better markers to assess the depth of a response. That's all it is. And that is through mechanisms such as genetic testing. And it's becoming increasingly clear, and I would argue now very well documented, that achieving that status where you can no longer find measurable disease. And this is with tools that are very sensitive. Some of them can go at the level of detecting one cell out of a million. That achieving that becomes a harbinger of great outcomes for patients, of durable responses, and ultimately improvements in the various metrics that we call survival. So, and that trial shows that, and it's very interesting to me for a couple of reasons. One is this is a different antibody, so this is a different molecule than daratumumab, but the presumption has been by those in the field that we should see similar results. That even these antibodies that they carry nothing of what we call a payload. It's just, we use the word, they're a naked antibody, meaning they just go and bind to those cells. And by doing that, they unleash kind of our immune response to those cells. They're able to kill more cells. And we know that because the responses are better and the MRD is better. In that particular trial, we have to wait for a little bit longer to see what the outcomes will be over time on those metrics that people hear about, like progression-free survival and overall survival. But all the indicators as well are, given what I said about MRD, that this will be a very useful approach for the treatment of patients. Now, the second aspect, which I find interesting, going back to our conversation, everyone should get a CD38, lenalidomide, and dexamethasone, at least for the time being. But then the question is, what about these drugs that we call proteasome inhibitors? And in this particular trial, they use carfilzomib. And for me, that's very interesting because that's what I do in my clinical practice. And when we make decisions in our clinical practice, there's trade-offs of the drugs we use. Carfilzomib is a sister medication to bortezomib. They're both proteasome inhibitors, but there's different toxicities that each one of them has. There's no clear-cut evidence that one is better than the other, although some have a remaining hypothesis, I would call it, myself included, that it's more effective. But I just don't like to see the enduring toxicity that occurs with some of the other drugs like bortezomib. So that's where we will be spending our time talking about those type of drugs. Should we use bortezomib? Should we use carfilzomib? If any patient is hearing this, I think both are standard of care, excellent treatment for you. So there's nuances of why we choose one or the other. And again, the second question will be transplant too as well. Because if you have these regimens that are able to make patients have such a great response that they become quote unquote MRD negative, then the question of, I already mentioned maintenance, but the question will come forward, do you even need transplant? For patients hearing this, I'm not saying we're ready to say we can dispense with transplant, but the data continues to show that deep responses, no matter how you get there, will result in better outcomes. So maybe some patients will elect to say, I'm going to collect cells and maybe think about a transplant later and so forth. That's a very long conversation, a nuanced conversation, but reflection just of the progress we're making with this type of combinations.
Dr. Ball, you were saying that things are becoming cleaner, but now we're thinking 4 drugs up front, but which 4 drugs? I think Dr. Fonseca was alluding to it, but are there any considerations that you take into whether your PI is going to be Velcade or Kyprolis, or what CD38 monoclonal antibody to use? Like, what goes through your mind now that you're picking 4 drugs?
Absolutely. So, I think that as Dr. Fonseca already mentioned too, I think the patient in front of you helps determine some of that. So, as you know, daratumumab versus isatuximab, these are both anti-CD38 monoclonal antibodies. They are both very effective drugs. However, one is subcutaneous, so administration's a little bit easier with the Darzalex or daratumumab, which is given as a a short injection underneath the skin. The other one requires an IV. So for now, at least, until we have the subcutaneous version for isatuximab, that does reduce chair time and patient convenience very much, I do believe. In terms of which proteasome inhibitor is the right choice, I think that some of that depends on the patient profile and what are some of their comorbidities that they already have. What is their age, for example? With bortezomib, we're aware that the risk of peripheral neuropathy is significant and can be quite disabling even at lower grades. However, with carfilzomib, we have seen cardiac and renal toxicities, and even more than just objective data. A lot of people complain of subjective dyspnea, subjective shortness of breath, things that can make it challenging for them to feel good on their treatments. So young, very robust, and perhaps high-risk patients are best stratified into the carfilzomib arms, and older patients, depending on their fitness, would then get either no PI or proteasome inhibitor or a bortezomib based option. So that's how we sort of think through when the patient's in front of us. But I feel like that part is rather individualized without any clear data of one being overly more efficacious than the other, at least based on the data that we do have in front of us.
Are there any groups of patients or any particular patients that you would not give the quad to? You would probably go back to triplet therapy or maybe even doublets.
I think incorporating, frailty assessment and assessment of the patient's overall performance status going beyond, the eyeball test that we do is going to be critical in determining who is really not fit to receive a quad. I think in those cases where there's concerns about use of a proteasome inhibitor, particularly bortezomib, due to underlying diabetes or other such comorbidities, or the patient's older and you're concerned about cardiopulmonary toxicity with carfilzomib, I think in those cases, as Dr. Fonseca also mentioned, daratumumab with lenalidomide and dexamethasone is an excellent option with high-level evidence of benefit. And the very old, I would say, patients who are in their high 80s, even 90s, I think in those patients I would consider a doublet. But what's interesting is that the doublet I would consider there would be a Daradex type combination or even Dara single agent type combination, because IMiDs require hematopoietic monitoring or blood work closely to be checked for low blood counts, and certainly the proteasome inhibitors carry all the concerns that we just mentioned. So in those patients, the very elderly, very frail, daratumumab is exceedingly both efficacious and quite safe as long as you provide them with appropriate antibiotic coverage and close monitoring, vaccination, and perhaps even IVIG use to protect them from infections.
What about maintenance? Are you saying single drug, double drug maintenance? Can you just touch about that?
Yes, no, thank you. I think everything was very eloquently said for what we're considering now as we think about this treatments up front. I think one of the points that Dr. Ball made, I want to emphasize. If you ask me 2 years ago, what would you do with a frail patient who has newly diagnosed myeloma, my response would have been lenalidomide and dexamethasone. But we saw with the subset analysis in the context of the clinical trial MAIA, that the addition of daratumumab significantly improved outcomes for these patients. And I'm glad we have the data because, we would be at significant risk of shortchanging patients in the line of thinking of beneficence. Let's be kind, use mild treatments, but it turns out that the survival numbers are not as good. Now, whenever we add a drug, we have to think, I'm going to add toxicity, but the reality is these antibodies are incredibly, incredibly well tolerated. It's different to propose adding carfilzomib or not versus adding daratumumab. So today, I would say most patients, the vast majority of patients, even if they're frail, they should get something like daratumumab up front. Now, to your second question, maintenance, that's really, really interesting. I'm hoping, and I think we're going to get there soon, and studies like the ones done by the group of Dr. Ball as well, too, that are using this adapted strategies to look at, can we stop therapy, naturally lead to the next question, which is, does everyone need maintenance? And I don't know what the answer to that is yet, but I know that the question is very relevant. And I think we're going to get to the point that we're going to think of maintenance like people think of like adjuvant therapy for breast cancer. I think many in the audience would be familiar. You complete surgery, they look at the lymph nodes, they look at the genetic makeup of breast cancer, and they say you need chemotherapy or you don't. I think as we incorporate our genetic knowledge, the status of response after induction plus or minus transplant, then we're going to ask those questions. Does everyone need maintenance? And I think it's going to diverge a little bit more to the extremes. There's going to be greater contrast. What I mean by that is as follows. I think patients that are able to complete induction therapy and let's say have a transplant and have MRD negativity 10 to the minus 6, and maybe they have standard risk genetic factors, it's going to be hard to prove on some of them that there would be added benefit of maintenance, maybe. And if so, hopefully something that's better tolerated, because as we know, lenalidomide has significant burden toxicities for patients. On the other hand, if the patient has residual disease, I don't think there's good enough reason to just say, well, that's what we do. That's standard. I'm just going to cross my fingers and maybe get a rabbit's paw wishing me luck that this is not going to come back. I think those are patients that we're going to provide additional treatment for no other reason than to try to get rid of all residual myeloma cells. What I say, quote unquote, let's finish the job. So I think that's where we're going to go with maintenance. So I don't foresee that maintenance as we have it right now, which was everyone gets lenalidomide, you get it until you can, tolerate it and hopefully not major side effects or no disease progression. I think that has to change.
As effective as the treatments are, myeloma still often comes back. And one of the exciting new treatments going forward is this CAR T therapy. So I guess I would first ask Dr. Ball, can you explain what CAR T therapy is, maybe in conjunction with the BMS CAR T that you presented at ASH?
Absolutely. Thank you, Jack. So CAR T cell therapy stands for chimeric antigen receptor T cell therapies. Within our bodies, as we had just talked about, there are immune cells, white cells. One of those subtype of cells are T cells, which are normally, working to keep our cancers in check. The thought is that, these T cells are not working as well as they need to be, and the cancer itself is finding mechanisms to evade our immune system, which is what results in disease relapse. And this is really a revolutionary therapy where, at least when we talk about autologous CAR T cells, meaning we take out a patient's own T cells by apheresis procedure, very similar to a procedure that patients go through when they do stem cell collection. So with that process, we obtain patients' T cells, and then in the lab, we essentially teach these or cells using a viral vector to express these new antigens on their surface or receptors on their surface that can target cancer antigens within a patient's body. And thereafter, we provide the patients with lymphodepletion chemotherapy, which is essentially chemotherapy that's given to reduce the number of T cells which are within the patient's body, and then infuse these chimeric antigen receptor T cells, which can then go in and interact with the antigen using their CAR receptor and cause cancer killing or tumor death. So this has been shown to be a very effective modality, particularly in patients who would previously not have very good treatment option after they've been through the three main pillars of therapy, like the CD38 monoclonal antibodies, immunomodulatory agents, and proteasome inhibitors. And these patients previously had dismal outcome measured in single-digit months. And now, with these therapies, they're living longer and are having excellent responses, including several that are MRD negative, even in this late-line disease setting. So at this time, there is FDA approval for two chimeric antigen receptor therapies in myeloma that target the B-cell maturation antigen. This is an antigen which is present on the surface of plasma cells with plasma cells in general, and more on the surface of malignant plasma cells, so the cancer cells. And using this target, we have seen very impressive responses, up to 98% overall responses with one of the FDA-approved agents known as cilta-cel or Carvykti. And so this is shown to be an effective avenue. What we presented at the ASH meeting this year is a chimeric antigen receptor T cell therapy, which is targeting a different antigen known as the GPRC5D antigen. And this antigen is also one that is expressed preferentially on the surface of these cancer cells and has limited expression across normal tissues, although we do see some expression on tissues such as hard keratinized tissues. We see it on skin, we see it on nail beds, we see it in the hair follicles, and we see some typical side effects, including dysgeusia or with treatments that target this therapy. So in what we have shown as overall GPRC5D has been shown to be a promising therapeutic target in myeloma. We already have a different immune strategy that's working against this and is FDA approved. And so in this phase 1 study, we evaluated a CAR T cell which is targeting GPRC5D on patients with relapsed myeloma. And what we saw is that in a heavily pretreated patient population who have received a median of 5 prior lines of therapy, that this was associated with deep responses overall in about 73 patients who were efficacy evaluable, meaning were evaluable for response assessment. We saw that 88% of the patients had a response.
Thank you. Dr. Fonseca, Dr. Ball mentioned that there are actually a couple of approved CAR Ts available for patients now, except the fact that they require 4+ lines of prior therapy. So there are trials and announcement of results from those trials like CARTITUDE-4 and KarMMa-3 that are testing these same CAR T therapy in earlier lines of treatment. Can you talk about the results of them, but tailor your answer to kind of patients' quality of life?
Thank you. Thank you very much, Jack. So you stole my thunder because I think that is probably the key aspect of all of this. And as you mentioned, there's 2 trials, the CARTITUDE-4 and the KarMMa-3, that are looking at this earlier on. KarMMa-3 with 2 to 4 prior lines of therapy, and CARTITUDE-4 with 1 to 3. And what they really explored is if they work well downstream, as it's true for every single myeloma drug, we cannot keep bringing them towards the forefront. And the results are quite remarkable. I think many of you saw the presentations and ultimately the publication of the CARTITUDE-4, which was presented at ASCO as well as EHA and published in the New England Journal. And what we're seeing is this treatment can provide very durable responses that can go on for years for some patients. And then, of course, the natural question is, well, how does this compare to other things? We have effective treatments that can work very well in someone who's experiencing a first relapse, such as could be a combination of daratumumab, carfilzomib, and dexamethasone, or isatuximab, carfilzomib, and dexamethasone. But the one big advantage that something like a CAR T has is that it's quote unquote one and done. And we're seeing patients that are reporting very, very high levels of quality of life and making statements like, I haven't felt this well in such a long time. And it's not necessarily because a CAR T gives you superpowers. It just gets rid of all of the side effects that come with treatment. Because even the most benign of treatments involves, logistics, medications, blood draws, what we would call the venipunctures, and then some of them have the side effects that come from the chemicals or the biologics that are used as side effects. And even in the best case scenario, it still is, it's just something that the patient has to do. And the idea that you're done, and then all that needs to be done is just occasional labs to monitor becomes very appealing. So I think that's probably going to be the number one driver. Of course, we're very excited. We're hoping to see these treatments have very, very long-lasting, benefits for some patients. But even if they were not for some, I think the ability to be treatment-free would be just beautiful.
Okay, so let's put this new hat on, bispecific antibodies. Dr. Ball, since you did such a good job explaining what CAR T cells are, bispecific antibodies, I hear patients sometimes referring to them as off-the-shelf CAR Ts, and I know they're not. Can you kind of explain the difference between a bispecific antibody and a CAR T?
Thank you, Cindy. Bispecific antibodies are antibody fragments. So I usually think of them as a little Y-shaped linker. That's how I typically describe them to my patients. So this is an antibody that has two prongs, if you will. On the one hand, it uses the CD3 molecule to catch the T cell, and on the other hand, it has a antigen receptor for one of the myeloma targets. Currently, we have bispecific antibodies that are targeting cancer cells using the same antigens that we talked about for CAR T cell therapy, such as B cell maturation antigen or GPRC5D. So they target the cancer cell using one of these antigens and then bring the two close so that cancer cell killing can occur by the immune system. So, one of the best parts about bispecific antibodies is the fact that you don't have this lag time or delay that comes with manufacturing associated with autologous or self generated CAR T cells. And these therapies are off the shelf, if you will. They utilize the patient's own T cells, bring them close to the cancer cells, and result in cancer cell killing. So, in patients, oftentimes where we don't have the time or the manufacturing capability or the slot allocation, or all of those patients who are not necessarily being treated at a large center with CAR T cell capabilities, this provides an avenue to use new immune treatments and immunotherapies for a wider range of patients. And I think it has a potential to reach many more patients given the current state of affairs, at least in 2023 and 2024, and so presents a very exciting option for our patients.
Dr. Fonseca, were there any major updates that we should know about out of ASH on bispecifics?
Yes. We had a number of updates, some of the longer term outcomes, and then some of the studies that are looking at bispecifics in various combinations, including with some of the traditional agents. I think I'm very interested to see how this actually plays out, because what we're seeing is that the bispecifics, first of all, are very active. Some could argue don't have as of yet the same horsepower as something like some of the CAR Ts. So, many of us are thinking of using them down the line. But some of them in combination are incredibly, incredibly active. So there's clinical trials that are looking at bispecifics, for instance, in combination with things like pomalidomide. Bispecifics between themselves. So there's a trial that combines talquetamab and teclistamab, the redirect trial. Bispecifics with daratumumab in combination. And just as excitingly, we have new constructs that are being developed. So we saw a presentation about something that is called a trispecific. So instead of just having one site that a bispecific can attach, there's bispecifics that could attach to two different anchor points that these myeloma cells have. Now, I particularly are interested in the bispecifics because I think the possibility that many more patients be treated is there for bispecifics than for CAR Ts, because CAR Ts require the centers of excellence, the referral patterns, and there's the wait times for the cell production. Whereas with the bispecifics, they're quote unquote off the shelf. So I think it's going to take some time, and people have to become familiarized with this. But in the future, we'll see community hospitals and mid-sized hospitals administering these bispecifics, which in my mind is wonderful because many more patients will derive benefit of these types of therapy. And for those in the audience too as well, you should know this is just the beginning of this new era in cancer treatment, because in fact, all of what we call the solid tumors are being explored for bispecifics. So things like lung cancer might be treated with things like this. So I think oncologists in the future will need to be certainly facile and comfortable with the use of bispecific antibodies.
Good. Dr. Ball, we said that CAR T cell therapy is a one and done type therapy, at least now. What about these bispecifics? Are they one and done? Are they weekly? Are they monthly? Do they go on forever? Can you talk a little bit about the dosing and schedule?
Yes, I'm happy to. So currently, there are three FDA-approved bispecific antibodies that are on the market. So we have two agents that are targeting BCMA. These are teclistamab and elranatamab. Both are bispecific antibodies targeting B-cell maturation antigen. These are drugs that are typically given as of right now, as their indication stands, on an ongoing basis until disease progression or unacceptable toxicity. Typically, these start out in the hospital with a small portion of inpatient hospitalization where patients receive step-up dosing to minimize the risk of certain side effects. And afterwards, they go on to weekly or every 2-week format. And in this fashion, they go on until the patients continue to respond or come off due to side effects. However, patients take about a median of a little over a month to respond to these agents and up to about 6 months to get into a complete response. And often these responses are very deep. And in those patients that come off because of side effects, we see that some of these patients are able to maintain their response for years without the treatment. So there's a lot of push about fixed duration of therapy, and one of the greatest reasons beyond patients having to come to the hospital or clinic and sort of the treatment and travel burden is the side effect profile. So these B-cell maturation antigen directed bispecific antibodies have a lot of infection risks. So 70+% of patients get infections, and 40 to 50% of these can often be grade 3 or higher, which can be quite serious. So these infection risks, particularly oftentimes infection with unusual things that we don't typically see in myeloma patients, has also enhanced some of our concerns about using these agents on a prolonged basis in patients whose disease may be controlled. So multiple factors are at play, and therefore there's a lot of interest in studying fixed duration therapy of these agents to really tailor it to a patient's response and then be able to discontinue these therapies once they're responding to optimize their risk and benefit profiles.
And that's good to hear. Now, Dr. Fonseca, we talked about CAR T cells. We talked about bispecific antibodies. Let's go with antibody drug conjugates. I think we had one that was approved through accelerated approval, then it was taken off the market for about, but now it may be back. Could you talk a little bit about the story of Blenrep?
Yes, no, thank you for the question, Cindy. So for our audiences, ADCs type antibodies are antibodies that carry kind of a payload. So there's usually a chemical entity that is attached to an antibody. And in general, what happens, the antibodies they bind to the cell surface and then they go inside the cell because they're engulfed, they're eaten into the cell, where they release whatever that chemical structure. So one of those antigens is this one, belantamab, which in fact, when it first started, it showed very, very high rates of response, actually quite promising responses. And it went through regulatory approval for a fast track approval. And unfortunately, there had to be a confirmatory phase 3 trial that did not meet the endpoint. So that means that the data for the trial would not support the complete approval by the FDA. So the product has been since withdrawn from the market, available on a compassionate basis. But this is a highly active compound. It does come with some baggage. One of the main baggage is toxicity to the eyes. So it's something we call keratopathy, and that's inflammation of the outside layer of the eye, the cornea. But I think as we're learning how to use it and better doses, that has been a little bit better tolerated. It's not to say it doesn't exist, but people are understanding better how to use this. And we just learned about 2 trials that are very exciting. One of them is where this was compared to daratumumab.
Thank you. And Dr. Fonseca, we patients always appreciate it when we learn that doses can be reduced. And then when we hear dexamethasone dosing can be reduced, we just get giddy about it. And at ASH, there was a presentation that looked retrospectively at a couple of SWOG trials, S777 and S1211, that looked at patients who had lower dex dosing. Can you talk a little bit about that and what that might mean to patients going forward?
Yes, thank you. Thank you, Jack, for the question. Whenever we discuss treatments with a patient, I usually emphasize that probably the hardest part of them is going to be the dexamethasone for the reasons you know better than I do. And the story goes back now several years. As you know, it all started with a patient, Michael Katz, who said, we get too much dexamethasone. What can you do about that? Which led to the design of 4A03, which changed our paradigm that we now use dexamethasone at what we call quote unquote low doses. But I can tell you, my endocrinology friends, when they see those doses, they call us and they say, what are you doing? This is a massive dose of dexamethasone. So that was a significant change. For those in the audience who don't know, we used to use 12 days per cycle. That is 12 out of 28 days at 40 milligrams of dexamethasone. So we've moved forward, but have not completely gotten rid of it. And from what we know now is as you go on with treatment, as was shown by the studies that you mentioned, as the patient gets stabilized, it becomes increasingly clear that the long-term use of dexamethasone is not contributing much to the control of the disease. And we know for sure it's contributing to the burden of side effects. It should be noted that there's several studies that are now showing that. So the clinicians need to be cautious and need to be adjusting the doses of dexamethasone. Now, at the beginning, I think most of us feel like you need a little bit of that dexamethasone to kind of quote unquote jumpstart a good response. But even then, you can do some adjustments for doses. So in patients of more advanced age, we often will use 20 instead of 40 milligrams, or in patients who have amyloidosis, we'll do adjustments like that. But it's important to be mindful of this because patients should not be on long-term, dexamethasone 40 milligrams once a week. In fact, in general, this is not something that we should be using long-term for maintenance. It can be used short-term for, consolidation, other reasons. So, I would tell patients, and as they probably heard through our messaging, we're very excited and positively so because of the developments in myeloma. But right now, if you're diagnosed with myeloma, for many, many patients, there are options such that myeloma should not be an immediate threat.
Thank you so much for your time today. We've learned so much. Thank you.
Thank you.
Thank you so much.